Welcome, colleagues, to today's Clinical Explainer. Today, we're getting into the absolute blueprint of oncology, the TNM staging system for doctors. We're going to break down exactly why clinical classification determines our therapy choices based on the four main stages, and why staging strictly guides our medical decisions from day one.
All right, let's dive right into this. Here's our clinical pathway for today. The universal language of cancer, the four stages of decision-making, reading TNM prefix codes, therapeutic weapons and cytostatic mechanisms, and finally, a metagenic classification and management.
So let's kick things off with a pretty provocative question. How can just a bunch of simple letters, T, N, and M, literally determine a patient's life or death? I know, it sounds overly simple, but these three letters are the entire foundation of the American Joint Committee on Cancer Staging System, or AJCC.
Part 1. The universal language of cancer and decoding the AJCC/UICC-TNM.
Think of this system as our oncological GPS. Without it, we're practically navigating blind. So first up, we have T for tumor. This describes the size and the extent of the primary tumor spreading into surrounding tissues, and the scale is incredibly methodical. We start at Tx, meaning it can't be assessed, to T0, where there's no evidence of a primary tumor, all the way up through the invasive stages T1 to T4, which represent progressive growth and deeper local invasion into the surrounding anatomy. Next, we're looking at N for node. This tracks the absence, presence, and really the extent of regional lymph node metastasis. We score this from N0, which is zero nodal metastasis, totally clear, moving up progressive nodal involvement from N1 to N3. This marks the increasing number and location of nodes compromised by sequential spread. Finally, we arrive at M for metastasis. And guys, this is the most critical factor for systemic spread. It simply categorizes the presence or absence of distant metastasis. It's very straightforward. M0 means none found, and M1 means distant metastasis is present. Now, how these three specific components combine is going to dictate absolutely everything we do next.
Part 2. The four stages of decision-making and grouping TNM.
Now, what's really interesting here is how this progression works and the hard rules behind it. We start at stage 0, which is your in situ carcinoma, completely non-invasive. Stage 1 is localized, a small tumor with no lymph node involvement. Stage 2 means a larger tumor with deeper local invasion, while Stage 3 brings in wider regional node involvement. But look closely at Stage 4. This is an automatic trigger. The second you have an M1 status, you're at Stage 4, period. That distant metastasis supersedes all other T or N status. And that is exactly why staging absolutely drives our therapeutic choices. Moving on to Part 3, reading TNM prefix codes and the timeline of assessment. We've got to make a hard distinction here between clinical and pathological staging. A lowercase c before TNM means clinical staging. That's based on your physical exams and imaging prior to any therapy. On the flip side, a lowercase p is pathological staging. That is based on the highly accurate histopathology of resected tissue post-surgery. Keep this key point in mind. Clinical classification dictates our initial therapy choices, while pathological staging confirms or alters the plan down the line. We also have a few other essential prefixes to round out our diagnostic vocabulary. A lowercase y denotes staging assessed after neoadjuvant therapy, like chemo or radiation before surgery. A lowercase r is used right at the time of tumor recurrence. And a lowercase a means staging determined at autopsy. All of these just provide precise timeline context for the patient's condition.
Part 4. Therapeutic weapons and cytostatic mechanisms.
For us clinicians, this is the explicit algorithmic workflow. Step 1, you assess the TNM components. Step 2, you determine the clinical stage. Step 3, you choose your cytostatic therapy exclusively based on that stage. And Step 4, which is absolutely mandatory, prescribe the anti-emetic protocol. Staging is the exact input that dictates our precise therapeutic output. And this brilliantly illustrates how our cytostatic weapons target different cellular phases. Instead of just relying on one mechanism, we combine them. Alkylating agents like cisplatin cross-link and damage DNA indiscriminately, independent of the cell cycle. Antimetabolites, on the other hand, hijack the S phase by mimicking normal metabolites. Then you've got topoisomerase inhibitors and mitotic inhibitors that specifically block cell division in the S, G2, or M phases. By strategically combining these classes, we're literally hitting the cancer from multiple angles, maximizing our chances of inducing tumor apoptosis. Which brings us to Part 5, a metagenic classification and management. Look, managing severe side effects is not just an afterthought. Without prophylaxis, the risk of acute emesis in that first 24 hours is brutal. We're talking greater than 90% risk in the highest tier, highly emetogenic chemotherapy, or HEC. That drops down through moderately emetogenic, low, and minimal, but that top tier is what we really need to watch out for. We absolutely have to recognize the heavy hitters in this HEC category, because using them mandates a maximum, highly aggressive prophylactic defense. We're talking cisplatin, the AC regimen, which is doxorubicin plus cyclophosphamide, dacarbazine and meclorethamine. Oh, and keep a close eye on high-dose cyclophosphamide, which is clinically defined as 1,500 milligrams per square meter or higher. To counter the HEC assault, one shield just isn't going to cut it. We deploy a 4-drug defense strategy from the MASC and ESMO guidelines. We block substance P centrally with an NK1 antagonist like aprepitant. We block peripheral serotonin receptors with a 5-HT3 antagonist like palonositron. We drastically reduce central inflammation with a corticosteroid, usually dexamethasone. And for high-risk or breakthrough cases, we bring in an atypical antipsychotic like olanzapine for multi-receptor blockade. It's a full-on defensive line working all at once. So the crucial point here, our golden clinical rule. The antiemetic regimen is determined by the most emetogenic component in the chemotherapy combination, not the overall average. If you give 3 low-risk drugs and just 1 HEC drug, you must prescribe the full HEC prophylactic regimen. Every medical practitioner needs to burn this protocol into their memory for patient safety and compliance.
To round out our holistic patient care, there are a few nuanced adjustments. Anticipatory emesis? That requires behavioral approaches in anxiolytics like lorazepam. Adding more serotonin blockers will do a thing. If breakthrough emesis happens anyway, you have to switch the mechanism, maybe adding a dopamine antagonist like metoclopramide. And pay attention to innate patient risk factors that require aggressive upfront treatment. Younger age, female patients, a history of motion sickness, and, surprisingly enough, low alcohol consumption actually increases risk. It's a small detail, but a major clinical pearl.
This all brings us to an incredibly important realization. Treating cancer isn't just about attacking the tumor based on a biological blueprint. The real question is, are you managing the patient's entire journey, from the precision of TNM staging all the way to complete symptom relief? The TNM staging system for doctors is our bedrock. It's why clinical classification determines therapy choices based on those 4 main stages, and ultimately why staging strictly guides our medical decisions. Thanks for joining me on this clinical deep dive. Hopefully this helps sharpen your practice.